Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel Stand Medical Notes and Lecture. So let's complete this topic of HHS. So in previous video we have discussed till diagnostic approach. So today we'll discuss about the management strategy in detail, special situations and pitfalls, and a practical case scenario regarding HHS. So first one is the management strategy. So key principle to remember here is fluid first and insulin later. So similar to diabetic ketoacidosis, there also you give fluid first, then after checking sodium levels, accordingly you will give insulin. Fluid first and insulin later. The brain adapts to chronic hyperosmolality by generating idiogenic osmoles. Rapid shifts in tonicity can cause severe neurological injury. How? Severe hyperglycemia causes massive fluid loss, 8 to 12 liters deficit. Brain adapted to chronic hyperosmolality. Rapid osmolality correction leads to neurological injury in the form of cerebral edema or osmotic demyelination syndrome, also known as central pontine myelinolysis, because of dehydration of brain. So because it is adapted to high concentration, when you dilute this concentration, what will happen? So the fluid from the blood will enter the neurons, and that will cause cerebral edema, okay, or osmotic demyelination. That's why fluid first and insulin. So when you decrease the glucose levels, when you decrease the glucose level by giving insulin first, immediately the hyperosmolality will meaning the concentration will decrease, and that will cause brain edema. So number one is fluid resuscitation, as we can see here. Most important initial intervention. First hour, give 0.9% normal saline, 1 to 2 liters IV. Next 12 hours, target positive fluid balance, 3 to 6 liters. 3 to 6 liters in next 12 hours. Next 24 to 40 hours, replace remaining fluid deficit. Total deficit often 8 to 12 hours. So 1 to 2 means 2 plus 6 is 8. So 8 liters you correct in first 12 hours, and remaining 4 you cover in the next 24 hours. Or you can correct, because it is 12 liter deficit, 6 liter you cover in the first 12 hours, then 6 liter in the next first 24 hours, and then 6 liter in the next second 24 hours. In that 1 to 2 liters in the first hour only. Okay. Adjust the fluid type, monitor corrected sodium, because because whenever you see increased sodium concentration, increased corrected sodium, then you change from 0.9% NS to 0.45% NS whenever appropriate. Special populations to take care is elderly patients, heart failure, and chronic kidney disease, because these patients are already fluid, they don't tolerate fluid much. It can result in pulmonary edema. That's why we should use smaller boluses, approximately 250 ml, to prevent pulmonary edema. Goal is to replace 8 to 12 liters of fluid deficit safely and restore the perfusion. Insulin therapy is second priority. Critical rule: never start insulin before adequate fluids. Why? Insulin moves glucose into the cells, water flows into the cells, sudden intravascular volume collapse, severe hypotension and shock will develop. So this can happen. Along with glucose, intravascular volume also enters the cells, and that results in decreased circulatory volume and severe hypotension and shock, and in brain it can lead to cerebral edema or demyelination. So when to start then? After initial fluid resuscitation and glucose fails to fall by 50 to 70 milligram per deciliter per hour with fluids alone. So insulin should be started only when the glucose does not fall by 50 to 70 milligram per deciliter every hour. If the insulin is falling less than 50 milligram per deciliter per hour, then only you should start insulin in these patients. Okay, 50 to 70. What should be the insulin dose? It is very much less when compared to diabetic ketoacidosis. It is IV regular insulin 0.05 units per kg per hour infusion, continuous infusion. And what should be the target? Same target, 50 to 75 mg. If it is going more than the target, then half the insulin dose. If it is going less than the target, then double the insulin dose. Same thing. But one important thing to remember here is this usually resolves only with fluid replacement. If the hyperglycemia is not solving with fluid replacement, then only you need insulin here. Otherwise, there is no need of insulin in these patients. Okay. And the dose is also less. Whenever it is required, the dose is also less. How do you decide when insulin is required? By seeing the fall of serum glucose levels, we will decide. So insulin is started only if fluids alone do not adequately lower glucose. Okay. Potassium management. Replace aggressively. Although acidosis is minimal, prolonged osmotic diuresis will lead to severe total body deficit, because along with fluid, electrolytes are also lost in the through the urine. That's why potassium replacement is very important. Maintain serum potassium in between 4 to 5 milliequivalents per liter before and during insulin therapy. Before also and during insulin therapy also. Important rule: don't ignore potassium. Insulin drives potassium into cells that can result in life-threatening hypokalemia. So follow diabetic ketoacidosis potassium replacement protocols. Monitor potassium every 2 to 4 hours. That means, so first of all, we don't need insulin. First, we will see in the first hour, we will give 1 to 2 liters of fluids to the patient. Now, if the glucose is falling by at least 50 milligram per deciliter per hour by fluids alone, then we will not give insulin, but we also check potassium levels. If the potassium levels are like less than 3.3, then we will hold insulin, then we will replace the potassium by 40 to 60 milliequivalents per liter. Like that we will replace 40 to 80. But if this is similar to DKA, if the potassium is between 3.3 to 5, you can say, then what we will do, we will add half of this, meaning 20 to 40 milliequivalents per liter we will add. If the potassium is more than 5, then we will not give potassium to that patient. Okay. And insulin, if you are giving insulin also, and if you are not giving insulin, in both conditions you check the potassium, and on the protocol of DKA you give the potassium to the patient. That is the thing. So first thing is no need of insulin if fluid only is correcting the hyperglycemia, but there is a need of potassium. Check the potassium levels every 2 to 4 hoursly and add according to the protocol of DKA. Osmolality monitoring to prevent neurological injury. Safe rate of osmolality reduction is 3 to 8 milliosmol per kg per hour. So this is the safe rate of osmolality. How do you calculate osmolality? So 2 into sodium in milliequivalents plus glucose divided by glucose in milligram per deciliter divided by 18. So this will give you the serum osmolality per kg. Okay. So you should monitor. So for that you need both glucose concentration and sodium concentration. So to have a correction of 3 to 8 milliosmol maximum, safe sodium reduction is less than or equal to 10 millimole per liter per 24 hours. Okay. Why? Goal is to gradual correction to protect the brain and to reduce the risk of cerebral edema and osmotic demyelination syndrome. So monitor effective osmolality and sodium every 2 to 4 hours. Every 2 to 4 hours. Okay. So one thing is you are getting here sodium as 10 millimole per liter. Okay. 1 minute. Okay, you are getting here sodium as 10 millimole per liter. So that is nothing but 10 milliequivalent per liter only. Okay. So meaning sodium should fall every hour less than or maximum equal to 10 milliequivalent per liter. That means we need to monitor potassium and sodium every 2 hours. Very important. So insulin has a less role to play in hyperosmolar hyperglycemic state than fluids, sodium and potassium. Sodium has a very high role because if sodium correction is very much high, if you are decreasing the sodium levels very fast, that can lead to osmotic demyelination syndrome. Okay, demyelination of the brainstem. So sodium has a very important role in this HHS and potassium also. Okay, and insulin has a secondary role. Okay, only when the fluids are not able to decrease the glucose concentration by 50 to 75 milligram per deciliter per hour. That is the only difference. And potassium replacement is similar to the diabetic ketoacidosis, and we need to monitor sodium concentration, and it should not fall more than 10 milliequivalents per hour. Okay, that we need to remember. In terms of osmolality, 3 to 8 milliosmol per kg. So HHS management in simple words: HHS diagnosis to aggressive fluid resuscitation. So 12 liters of fluid correction in 48 hours. Correct sodium and monitor osmolality. See, sodium role is very much high in HHS, and replace potassium. Start insulin only after adequate fluids. Controlled reduction in glucose and osmolality leads to safe recovery. Remember, patience and careful monitoring save lives in HHS. Okay, monitoring is very important and patience is very important. One take home message here is fluid replacement is the primary life saving treatment in HHS. Do not start insulin before adequate fluid resuscitation. Replace potassium appropriately before and during insulin therapy. Okay, lower osmolality slowly, 3 to milliosmol per kg. That's indirectly, that is lower the sodium concentration less than 10 milliequivalent per liter per hour. Monitor closely vitals, urine output, sodium, potassium, osmolality and mental status of the patient. This is the mental status of the patient. That's our the management strategy in simple ways of your HHS and the differences between the management of HHS and diabetic ketoacidosis. Coming to special situations and pitfalls. So you can see here. So number one is premature insulin initiation in management. Administering high dose insulin prior to volume expansion in HHS leads to the rapid intracellular shifting of glucose and water that will lead to intravascular volume collapse, meaning shock. This abruptly empties the intravascular space, triggering catastrophic cardiovascular collapse. Fluid resuscitation must absolutely lead the therapeutic charge. Fluid first, insulin later is the key point. Never start insulin until adequate volume resuscitation is achieved. Second important point is thromboembolic complications. Very important, very important. The extreme dehydration and hyperosmolality in HHS results in severe blood hyperviscosity. So severe dehydration will lead to increase in blood viscosity that can lead to stroke, deep venous thrombosis, mesenteric ischemia, even MI also. Okay, brain stroke, MI, deep venous thrombosis, mesenteric ischemia. This should be kept in mind. This significantly elevates the risk of DVT, stroke and mesenteric ischemia. That's why prophylactic anticoagulation is mandatory unless explicitly contraindicated. You can give 60 mg prophylactic, no, so 60 mg enoxaparin subcutaneously OD, or you can give 5,000 international units of low molecular weight heparin BD. You can give IV or subcutaneously. So most commonly this is only used. Okay, so key point is high risk of thrombosis in HHS, use prophylactic anticoagulation unless contraindicated. Another thing is neurological monitoring. So first thing is early initiation of insulin should not be done unless volume resuscitation is done. Second thing is keep in mind the thrombotic complications, so give prophylactic heparin. Third is neurological monitoring. Neurological deterioration during treatment suggests overly rapid correction of osmolality leading to cerebral edema. This requires immediate osmotherapy. What is that osmotherapy? Either you give mannitol 20% or 3% sodium chloride. So if patient mental state is deteriorating, then you should think that the osmolality is falling very fast, and if patient develops symptoms in the form of focal neurological symptoms, headache, seizures, then give immediately anti-edema measures like mannitol, IV mannitol or 3% sodium chloride. Monitor neurological status closely. Act quickly if deterioration occurs. So take home message is correct volume first. Do not rush to insulin. High risk of thrombosis. Use prophylactic anticoagulation. Monitor neurological status. Prevent and treat cerebral edema. There is a very much high risk of cerebral edema in case of HHS. That's why we need to give fluid first and give prophylactic anticoagulation, and we should prevent cerebral edema, and if it occurs then we should treat cerebral edema. That's all about the HHS. Now we will come to a practical case scenario of management of HHS. Okay, now here is a patient named Ramesh, 72-year-old male with type 2 diabetes mellitus for 15 years, hypertension, CKD stage 3 and recent pneumonia with poor oral intake. See here, this is a very important point. For 5 days recently he had pneumonia with poor oral intake because the thirst mechanism is impaired in elderly individuals. Now he presents to the ED with progressive weakness, excessive thirst, polyuria, increasing confusion and drowsiness, meaning CNS symptoms and symptoms of hyperglycemia. Okay. Initial examination reveals sunken eyes, dry tongue with furrows, poor skin turgor, confused patient but arousable, resting tachycardia. Okay. This alone will give us a clue that the patient has lost approximately 10 liters of fluid. Initial vitals revealed BP less than BP 80 to 88 by 54 mmHg. Very much, meaning there is hypotension. And heart rate is 124 per minute, tachycardia. Respiratory rate is 22 per minute, slightly elevated. Temperature is 38.5 degrees Celsius. Temperature is also elevated. SpO2 95%. Saturation is normal. Okay. So respiratory rate is elevated, saturation is normal. That means there is acidosis. Okay. So initial lab results, glucose is 980 milligram deciliter. See how much it is elevated. So it is very much elevated in HHS. Sodium is 150 milliequivalent per liter. Potassium is 4.8. Okay, it is normal. Sodium is elevated. Okay. Bicarbonate is 22 milliequivalent per liter. Bicarbonate is raised. Actually, it is not decreased. Okay. pH is 7.36 normal. There is no acidosis. BUN is 62 milligram per deciliter raised. Creatinine is 2.3 raised. Ketone bodies are traced. That means there is minimal ketonemia. Okay. Lactate is normal, meaning there is no acidosis. Sorry, very much sorry. There is no acidosis. So first we need to calculate. So because we are suspecting, because there is hyperglycemia, typical the case is revealing us the patient profile is typically of HHS. Sodium is also elevated. Hyperglycemia is also there. Sodium is also elevated, but pH is not. So we are suspecting this one. And we are calculating effective osmolality 2 into sodium plus 980 by 18. So it is revealing 354. That means there is hyperosmolar state. Diagnostic criteria is fulfilled. Glucose is more than 600. Effective osmolality is more than 320. pH is more than 7.3. Bicarbonate is more than 18 equivalents, and there is minimal ketones. Final diagnosis HHS, which is precipitated by pneumonia. Because of pneumonia, patient has not taken oral intake. So that means in elderly individuals who have chronic diabetes states with comorbidities like CKD, they should have a very good oral fluid intake in this acute circumstances like pneumonia, when they have infection, when they have dehydration. Otherwise they will end up with HHS. This need to be kept in mind. Key principles: fluid treatment, fluid first, insulin later, correct osmolality slowly with patience, monitor potassium continuously, and treat the precipitating cause. Okay. So now we are managing the case. So in the first day, 0 to 24 hours. So in first hour, we have given 0.9% normal saline over half hour and 1 liter over the next half hour. So vitals are monitored every 15 minutes. Urine output catheter is inserted. Cardiac monitoring is attached, and neurological observation is done. At the end of 1 hour, BP is increased 102 by 64. Heart rate is reduced 112 by minute. Urine output is okay, 120 milliliter. Glucose is still high. See, it is 930 milligram per deciliter. Glucose falling with fluids alone is not. Glucose falling with fluids alone. How much it was initially? It was 980. Yes, glucose is falling. So it started 980 and it has fallen to 930. That means 50 milligram is fallen. So glucose is falling with fluids. So no need of insulin still. Okay, no need of insulin. Sorry, no need of insulin. Hour 2 to 6. Continue the fluids, 0.9% NS, 250 to 500 ml per hour. Search for the trigger. Send for CBC, blood culture, chest X-ray, urine culture. Okay. So result is there was pneumonia. Antibiotics were started. Ceftriaxone plus azithromycin. Azithromycin will cover the atypical and gram positive. Ceftriaxone will cover the gram negative. Hour 4 lapse at the 4th hour. So the glucose every 2 to 4 hours we should monitor. No, that's why. So glucose is 820 milligram. Again it is decreased. Sodium is 152. Okay, sodium initially it was 150. No, now it is 152. Potassium is 4.5. Osmolality is decreased. See, it is 345 millismol per kg. So here it was initially it was how much? 354. So it has fallen by 6 plus 5 is 11 milliosmol. So observation is glucose is falling appropriately, that is more than 50 milligram per deciliter. So still no insulin is required, and sodium is 152. 150 it is increased 152. So hour 6 potassium monitoring. Okay, potassium is equal to 4.1 milliequivalent. Action, add potassium chloride. Yes, similar to DK, 20 to 30 milliequivalent per liter to IV fluids. Target potassium 4 to 5 milliequivalent per liter. Hour 8 start insulin. Glucose reduction slows. Fall rate is now it is less than 50 milligram per deciliter per reverse. Start regular insulin infusion 0.05 units per kg per hour. Why we are starting? Because the reduction is glucose is now decreased to less than 50. Weight is 80 kg. So dose is 4 units per hour. No insulin bolus, no aggressive insulin. Okay. Hour 12 reassessment. BP is 118 by 72. Heart rate is 96. Glucose is fallen by 550 milligram per deciliter. Osmolality is decreased now 336. Initially it was 350. Okay. Now it is decreased. And potassium is 4.2. So fluid balance of 4.5 liters. Mental status is improving. Patient is less confused following commands. Hour 18. Every 4 hours we are taking action and seeing the vitals and electrolytes. Adjust fluids. Correct the sodium. Sodium is still elevated. So correct the sodium. Switch to 0.45% NS. Monitoring targets. Osmolality reduction should be 3 to 8 milliosmol per kg per hour. Sodium reduction should be less than 10 milliequivalents per liter per day. Per day it is, remember, per day, not per hour, it is per day. Hour 24. So BP is 124/76, heart rate 88, glucose 320, osmolality 318, okay. Potassium is 4.3. Mental status is still improving, alert, oriented to place and person. Now dextrose added. Dextrose adders add T5 0.45% NS. Glucose is falling less than 300 to 350 milligram per deciliter. Continue insulin infusion. So in DKV we were adding this D5 when the glucose used to fall less than 250, but in HHS we are adding D5 whenever the patient is on insulin and the glucose level is fallen less than 350, remember, less than 350. Okay, so practical scenario management of now. Hour 36, near resolution. Glucose is 240, osmolality is 305, okay. Sodium is 145, potassium is 4.4. Patient has a normal urine output, stable BP, no confusion, eating orally. Hour 48, transition to subcutaneous insulin. Total daily dose 80 into 0.5 is 32 units, basal bolus is glargine 60 units, Prandtl is 5 units before meal, okay, plus correction scale, okay. Insulin infusion stop rule is give basal insulin after 2 hours. You can give, you can stop IV insulin. That is the thing. Okay. Resolution criteria: effective osmolality should be less than 310. So which is achieved here 305. Okay. So osmolality should fall less than 300 to 310. Mental status should normalize. Hemodynamic patient should be stable, adequately hydrated, eating and drinking. Trigger treated. Day 3 final outcome. So this patient Ramesh's pneumonia is improving, mental status is normal, osmolality is normalized, renal function is recovering, ability independently, discharge in stable condition. Discharge diagnosis: hyperosmolar hyperglycemic state precipitated by pneumonia and dehydration, successfully treated with stage fluid resuscitation, cautious insulin therapy, potassium replacement and control osmolality correction. Key learning points: fluid first, insulin later strategy. Never rush osmolality correction. Slowly you should decrease, that is 3 to 8 milliosmol per kg per hour. The osmolality should decrease, that is per hour only, no? Per hour. It was there. And monitor potassium continuously. Treat the precipitating cause. Resolution is defined by normalization of osmolality and mental status. Two things: mental status and osmolality, not glucose alone. Osmolality should come down to less than 300 to 310. That's all about the your HHS. Thank you.